I was walking through the partial denture department the other day and saw this doozy of a case. A doctor sent this one in requesting a review and a proposed design of what we could do. You could see the patient's missing teeth number 3 through 10, but has some nice rest preps from the existing partial that they had before, which is broken. In fact, it's got a history of the teeth breaking from the settle several times. And if we look, we can see there's little room for denture teeth from 3 through 5 at least. And you can see the class 3 arrangement that we have there. If we were to put denture teeth in there with this bite, the denture teeth would be very, very thin and most certainly fracture. Patient's coming back to doctor angry again. And so as we look at it and try to figure out what it is, we see the patient has a lower partial denture, and the teeth, the acrylic teeth, are basically worn down to the mesh at this point. And so you look at this, and that's where this tooth has been hitting, just eating down into that, whereas before it was probably up on a normal occlusal plane, not quite that tilted, but the bite was definitely open before. So there was a couple of different options that were run by the doctor. The first one was remake the patient's lower denture as well. There's been a lot of wear on the other side, not as much as over here, and there's an anterior segment to it as well. But if the lower denture gets remade, all of a sudden the teeth, for example, can continue along the occlusal plane here, along kind of a modified curve of Spee, and at least we'll have enough room then when the patient bites together and stops here for the rest of those teeth that are on there. And the patient called back and said, the doctor called back and said the patient can't afford this option. So another option would be for the doctor to take a pickup impression with this partial in place and then to pick it all up, send it out to the laboratory, and we could pour that, and then we could add new teeth onto both of the saddles, and we could do a wax up on the opposing and get an appropriate plane of occlusion on this lower denture, and then fabricate the upper to that and send them both back to the doctor to have them be delivered at the same time with the occlusion adjusted. Or the last thing is the doctor could, and this might be the most affordable just in terms of the lowest lab bill, the doctor could build these teeth and a little bit over here back up again with tooth-colored acrylic perhaps, or composite. Composite doesn't necessarily stick at all to denture teeth, but with enough potholes in here, if he wanted to use composite, he might be able to do it, or use some acrylic to be able to do it as well. So the doctor liked the idea of building it up with acrylic, almost a block as much as the teeth, just to be able to open it up. And so the doctor is going to build that up and get an impression of that for us and get a bite. And in the meantime, the framework has been made, and so I'll put this into place. And you can see that number 11 has been clasped with again, we would term this an aesthetic clasp because it's not out on the facial and therefore readily apparent. Any clasp on number 11 usually will be seen. And so there's an undercut on the mesial, and the opposing does not interfere with the lingual. And so there's room to come off the cingulum and wrap this around the lingual and onto the mesial into that undercut. The doctor approved the horseshoe major connector that matched the patient's existing partial denture, and we try to design the major connector as similar as possible to what the patient has already accommodated to, in the past to their tongue. So even if we see something that might be a more clever design or might be a smaller palatal strap, if the patient is used to something and hasn't complained about it, it's often the best idea to go ahead and replicate that and make sure that they don't have to learn something all over again. So if we can see the indentation on their palate where that was, that's even more helpful. Again, we have an eye bar over on this side. This tooth has already lost some of the attachment, and the eye bar is a very kind way to be able to clasp that compared to a circumferential clasp like this one, but that tooth is much stronger than that bicuspid and doesn't have the same attached gingival loss and perio issues that the bicuspid does. So the doctor is going to build up the lower denture with composite, open the bite so that there's room, because otherwise it would be very difficult, as you can see, to place denture teeth in acrylic there. And it's no wonder the patient has continually broken the teeth off of his existing partials.